Next, I want to talk about the pharmacologic treatment of substance use disorders, and we're going to talk about alcohol and opioids. So what are our options? Let's say someone has stopped drinking. How can we help? Well, we can help with replacement. There's one drug called acamprosate that was developed as a GABA analog. So you basically supplement a bit of GABA, and that may help to have something on board what is similar to alcohol. Now another way is inhibit rewarding effects. So once you would drink again, that you don't feel very well. And so there's one drug, it's called naltrexone. Naltrexone. Don't confuse it with naloxone. Sounds very similar. It's also a mu antagonist. But in contrast to naloxone, which has a very short half-life and is administered mainly IV, IM, and subcut, this is an oral drug. This has a long half-life, so you take it once a day. And then this is a mu antagonist, so it blocks the mu receptor. Now it turns out pharmacologically that alcohol also leads to the release of endorphins, and that's what makes us feel good. We have more endorphins around. So if the patient drinks again, these mu receptors are blocked that usually the endorphins work on, and you're not going to feel good. Another way, kind of more brutal, is the drug disulfiram. Disulfiram. That's under the brand name. It's just a famous brand name, so I'm going to put that down. Antabuse. And what does this do? Well, when alcohol is degraded, there's an enzyme involved. It's called the aldehyde dehydrogenase. So this drug inhibits aldehyde dehydrogenase. So this is important for the breakdown of alcohol, and if you don't have that, you're going to accumulate acetaldehyde. And that's a very nasty substance. It makes you nauseous. It's going to dilate your blood vessels, particularly in the skin. You're going to turn red. You're not going to feel very well. There are some people who have a mutation in this enzyme, and that's how they always feel when they drink alcohol. They turn red. This is also a vasodilator, so you're going to get headache because it also dilates cerebral blood vessels, and you're just going to feel very nauseous. So that's a drug if the patient wants something to have on board and to feel really terrible in case the patient drinks again. That's an option. Antabuse. Now, when we're thinking about opioid substance use disorder, well, we're mainly working with replacement. So we want to have the patient off heroin. So we want to give something that is long-acting, that just replaces the heroin. And the most used drug is methadone, which is a full mu agonist. It's a very long half-life, so it really tapers itself off. It's so you're not going to have withdrawal symptoms. So you're just going to be off heroin and on a replacement. And then obviously at one point you're going to hope to get off methadone. There's an alternative that's called buprenorphine, and that's a partial mu agonist. Well, that's also replacement, very long half-life, so partial stimulation, so not full stimulation, but you still have something on board. And now this has the other advantage because it's a partial mu agonist, so in case the patient would have another shot of heroin, now you have a partial mu agonist on board. And if you remember from your pharmacologic principles, a partial mu agonist acts as an antagonist in the presence of an agonist. So because they all compete, heroin is not going to win the game. There's this partial mu agonist around, and that will also occupy the mu receptor, so the patient will not get a full kick on heroin. Now, there is the possibility that the patient could crush these tablets and inject it IV and still get a pretty good kick, even if it's a partial mu agonist, if you take it IV. So what has the pharmaceutical industry done? It's gonna combine buprenorphine with naloxone. That's under the brand name Suboxone. And this is a mu antagonist. So now, what is the pharmacologic relevance basis behind this combination? Well, the important thing is that this has poor oral bioavailability. So if you take the drug as you should, meaning oral, the naloxone will basically be gone because there's a super high first pass metabolism. So it's out of the system. It's not even getting into the system, you can say. So buprenorphine will do its job. But if the patient would crush it and want to inject it IV, then this comes into place because that is going to work IV. So we have naloxone on board and the patient would not get a kick with buprenorphine if the patient would inject it IV. So that's the idea of this Suboxone that you may have heard about. Now, a replacement is number one. We could potentially also say inhibit rewarding effects. So just in case to have something on board, kind of similar to here, this naltrexone is also used in opioid use disorders, similar to alcohol use disorders.